Hello, my name is Judy Hung, and I am president of the ASE. I'd like to welcome you to this special session of the ASE 2021 called Sound Saves Lives. The mission of the ASE is to advance cardiovascular ultrasound and improve lives through excellence in education, research, innovation, advocacy, and service to the profession and the public. This special session highlights from the patient perspective how echocardiography has made an impact in their lives. We have two wonderful stories to share in this session. The first comes from Melissa at Mass General Hospital for Children.
My name is Joanne Chu. I'm a fetal cardiologist at Massachusetts General Hospital, and we will be presenting a case of a fetal patient who had two children that we saw in our fetal cardiology clinic.
Hi, I'm Joanna, the fetal cardiac nurse, and Melissa was seen here at MGH for her level 1 ultrasound on November 8th, 2017, and that was concerning for a nuchal translucency of 7 millimeters. She had a CVS karyotype that was normal, and then a microarray was sent, which came back with a possibly pathogenic deletion at chromosome 8p23.1. The family met with a genetic counselor on December 13th to discuss the results, and they were offered a level 2 ultrasound for that day, and that was suggestive of an AV canal defect. So she got referred to us for a fetal echo, and these prenatal diagnoses always come as a shock to families, and the uncertainty can cause a lot of anxiety. So we tried to get her in as quickly as possible for her study, and we were able to schedule her exactly at 18 weeks, and that echo confirmed the AV canal defect.
So my name is Melissa, and the first time I heard that there was a congenital heart lesion, it was quite scary for us because we didn't know what to expect. Coming from not knowing anything about heart defects or anything in that aspect was pretty scary. I would have to say that everyone at the clinic was excellent in explaining, what to do and what we were going to expect going forward. Every time we met with Dr. Arya and the other doctors, they gave us a rundown of exactly what to expect every time, even though they had explained the time before that, which was amazing because you sometimes get confused or you're not expecting what's to come or you're too overwhelmed. So that was awesome.
My name is Talia. I'm the pediatric and fetal echocardiographer. From the first fetal echo, we were able to see that the baby did have a balanced, complete AV canal defect. The axial 4-chamber imaging allowed for optimal assessment of an AV canal defect, looking at the common AV valve and the crux of the heart during systole and diastole. This information can tell us the size of the defect and help prepare for life after birth. The primum ASD was moderate size with a large inlet VSD with extension into the outlet septum. Some of the aortic and mitral dimensions measured low normal. We continue to watch and measure those throughout the pregnancy to make sure they didn't become hypoplastic, progressing to a right dominant AV canal. The ductus arteriosus flow was laminar with no obstruction. We also look at size discrepancy between the ventricles with AV canal defects, and the sizes in this case were proportional with, which is balanced. It is very common that there is AV valve regurgitation in AV canals. This patient only had a trivial amount of regurgitation.
So the diagnosis of an atrioventricular septal defect in utero can be challenging, particularly those subtypes with a small primum defect, like a partial AV canal. But diagnosis of a complete AV canal defect is often diagnosed and referred by our maternal fetal medicine colleagues, given that there's dropout in the endocardial cushion region with defects in both the atrial and the ventricular septum. Fetal predictors for increased mortality, both in utero and postnatally, include the presence of heterotaxy syndrome, unbalanced AV canal, like a right dominant AV canal defect, rhythm abnormalities, including bradycardia or complete heart block, a non-compaction appearance of the myocardium, extra cardiac anomalies, and the presence of high drops. Reassuringly, in Melissa's baby, there was a balanced AV canal defect without significant right or left-sided AV valve regurgitation, with normal biventricular systolic function and a lack of extra cardiac anomalies.
So after her initial echo, we plan to follow Melissa and baby very closely during the pregnancy, along with her OB team, genetic counseling, and social work supports as needed. So she was seen by us for fetal echo again on January 12th, 2018, March 9th, and April 20th. During the January visit, we discussed the signs and symptoms to expect once the baby was born, the timing of the surgical repair, and the plan for delivery. The family knew our team was there throughout the pregnancy and for evaluation once the baby was born.
For the remainder of my pregnancy was pretty scary. My husband and I, we weren't sure if we were going to abort the baby or if we were going to keep the baby from a standpoint of what we would be able to handle in everyday life and what would be to come after that. So we met with a counselor and up to the very last moment of being able to abort. We made our decision then, but before that, it was a lot of crying and upsetness. After the 6 months, I felt a huge relief of knowing that there's not much conflict between the two of us anymore, and that we could concentrate greatly on our child that was going to be coming. There was a lot of research that we did, and again, all the doctors that we met with were amazing and helped us prepare for what was to come. We were very prepared for having to kind of know the signs and symptoms that we would need to know about when she was born, knowing about like breathing and what to expect during surgery and whatnot. So it was very helpful.
So Madison was born at 37 weeks, had a stable postnatal course, and was discharged at 4 days of age. Her first postnatal echo findings were the same as the fetal echo, a balanced complete AV canal defect with a small to moderate sized primum ASD and a moderate sized inlet defect that extended anteriorly. At this point, there was mild regurgitation through both the left and right AV valves.
Once Madison was born, there was obviously the great joy and excitement of having your first baby. There was the fear of the kind of the unknown, since you just don't know what your child's going to be like compared to other children that you have been told about. When she was first born, it was very much being a parent that was on top of your child all the time, like a helicopter parent, making sure that she was, when she was sleeping, that she was breathing, not turning blue, just because you're just not sure of that you're doing the right thing. When she was first born up until maybe 2 years of age, we never really let her cry because we were afraid of the strain that it would take on her heart. But now that we know she's healthy, now we don't have as much of a problem letting her cry or doing exercises and stuff like that. It's just kind of at the beginning, making your way and seeing what works for you and your child.
So when Madison was 4 months old, she underwent complete AV canal repair with a partial mitral valve cleft closure using the 2-patch technique, and she had residual moderate mitral regurgitation and mild to moderate tricuspid regurgitation. She went back to the OR for a second surgery 3 weeks later for a mitral valve repair, including closure of the cleft and a posterior annuloplasty and a tricuspid valve repair. Postoperatively, there was improvement in the AV valve regurgitation to the trivial range, and the discharge echo demonstrated mild mitral stenosis with a mean gradient of 5 millimeters of mercury.
After the first surgery was quite a shock to us, just kind of seeing what she looked like coming out of surgery. She looked pretty intimidating, but all the nurses and doctors were great. It was amazing being able to hold her the first time after surgery. It was like having a new baby. Between the two surgeries, we didn't get a whole lot of time. She had her first surgery we were planning on going home. We had our discharge echo, and we found out that she was going to have to go under again to have the repair before we went home. The time in between was very exciting because we thought we were going to go home. And then the time right before her second surgery was very scary because she had gotten very, very sick very quick. So that was quite a shock, and we kind of weren't prepared for it. And you never know what's going to happen to your child when you see something like that happen. So all the doctors and nurses were great explaining everything, and she was able to get in super quick for her second surgery. And I guess it was good from there.
So she developed severe mitral stenosis, moderate regurgitation, and pulmonary hypertension after 2 cardiac catheterizations and a balloon dilation of the mitral valve with data reflecting increasing left atrial pressure, elevated pulmonary vascular resistance, and worsening mitral stenosis. She ultimately underwent a 3rd surgery at 10 months of age with a Melody valve placement in the mitral position.
Life with Madison, now that she's had her 3rd open heart surgery, has been amazing. You would never know that she had anything done. She's like your average, every kind of kid out there. Her follow-ups have been typically every 6 months, which is fabulous, considering we were there very, very often when she was younger. We're not looking forward to her next surgery, and we're hoping that it'll be as long as we can in between. But with the surgical team and nurses behind us, we're prepared for it, and we're just really, really happy that they tried the valve that they did on her, because it seems to be working out fabulous.
So fast forward a couple of years from when we first met Melissa, I got a call this past November from one of our OBs who was requesting an urgent fetal echo. He gave me the name, and I was like, oh my gosh, we know this patient. So we took a look to see where we could fit her in, and had her come to our Foxborough location that day for an ultrasound. So what happened was, at her routine prenatal visit, she was 28 and 2, a fetal arrhythmia was detected by the Doppler. So on her fetal echo that day, we saw intermittent SVT. And so we just took Melissa on again and started following baby number 2.
So finding out in Waltham that my second baby might have some heart issues going on was a little bit scary, but I was very glad that they were able to get me in right away and be able to kind of assess things as soon as possible, so we weren't waiting around kind of playing around with what could be, what could not be, and getting things done as soon as possible.
We got the call in Foxborough that we had an add-on fetal patient coming in for SVT, which would entail considerable time assessing the rhythm of the heart, recording long loops and measuring the heart rate both in the atria and the ventricles, along with evidence of one-to-one atrioventricular association. With any patient referred for fetal arrhythmia, one way we can confirm one-to-one conduction is by assessing pulse wave Doppler of the mitral inflow and aortic outflow on the same Doppler tracing. We also use MO tracing by placing the cursor across the atria and ventricle, again assessing one-to-one atrial and ventricular contraction. On both of these tracings, we can also measure the beats per minute for both the atria and ventricle. SVT can come and go, so it's important to watch and see how long and how often the baby is in SVT. During the first fetal echo, the baby was having frequent PACs and 3 to 8 beat runs of non-sustained SVT with rates of 190 to 203 beats per minute.
On her initial 2 fetal echoes obtained a few days apart, there was less than 50% atrial ectopy, though there were frequent PACs and conducted atrial bigeminy, trigeminy, quadrigeminy noted throughout the scan. There were no sustained runs of tachyarrhythmia during the study, and in a fetus with PACs, the risk of fetal tachycardia is about 0.5 to 1%, although couplets and blocked atrial bigeminy may increase this risk. So for her at that time, medical treatment wasn't indicated, with reassuring biventricular systolic function and a lack of high drops, though we were monitoring her very closely. On her third fetal echo, there was 1-to-1 atrioventricular rhythm with sustained atrial ectopy, a rate of 180s to 190s, over 50% of the study, and the baseline heart rate was in the 140s. So fetal tachycardia has a broad differential, including sinus tachycardia, which might be from infection, maternal thyroid dysfunction, and anemia. Rare dysrhythmias, including persistent junctional reciprocating tachycardia, or PJRT, or ectopic atrial tachycardia, EAT, that would fall into this heart rate range. It might be ventricular tachycardia, atrial flutter, or orthodromic reciprocating tachycardia. Typically, that would be with a heart rate of over 220 in the 250s and 260s range, which was inconsistent with her findings. So the diagnosis of the tachycardia type, to the best of our abilities by fetal echocardiogram, involves assessing the atrial and ventricular association, the interval between the two pulses, so if it's a long versus a short RP tachycardia, and it's really essential in determining appropriate medical treatment. Melissa's scans demonstrated fetal 1-to-1 atrioventricular association with evidence of PACs and a long VA time, for which the differential includes sinus tachycardia, EAT, and PJRT. But given the heart rate range, the characteristics of the rhythm, this was likely EAT, although orthodromic reciprocating tachycardia and PJRT were possibilities, and it can be difficult to distinguish that in utero.
When we had decided to move forward with being hospitalized and started on the medication, I was not as nervous as I thought I would be. I was very comfortable with my team that was behind me and making the decision that was right. I just wanted to do what was right for my baby. So simply being put on a medication was nothing compared to all the stuff that Madison went through. I thought that it was less scary of a thing to go through than what Madison went through as well. The team, when I was hospitalized, was amazing. They did everything that they had to do to look at the baby, look at the heart. We got ultrasounds as frequent as needed. They gave us 3D pictures. They did all kinds of excellent things for us while we were in the hospital. It was always nice having already worked with some of the people that had worked with Madison, being able to work with them again, and just having all the trust that I've had with Madison on my second baby as well.
So we admitted Melissa to the inpatient service for initiation of digoxin with an IV loading dose, followed by oral maintenance dosing. She was monitored on telemetry and also followed by the adult cardiology team. Digoxin levels and maternal side effects were monitored, and it was very well tolerated.
Following successful medical termination of the fetal arrhythmia, Melissa continued on her maintenance oral digoxin therapy with controlled fetal rhythm. There was no ectopy, including runs of SVT, on any of her last 5 fetal echoes, and the heart rate was normal during all of those echoes, ranging from 130 to 160 beats per minute with 1-to-1 conduction.
The rest of the pregnancy went great. There were no issues that I can remember reporting. Everything was pretty smooth at delivery. When they decided that it was time for me to deliver, they wanted to know if I wanted to push, but it was kind of a decision that the doctor had made, that the gynecologist had made, that we should have a C-section. So it was a little scary thinking that I would try to push out a baby with heart numbers that weren't perfect. After the delivery, he was in the NICU for a little bit, maybe 24 or 48 hours. He did great on his stay there. He was taken off the medication and monitored for a couple more days, and we were able to leave the hospital at the same time, which was one of my fears, of having to leave him in the hospital by himself and going home without him. Ever since having him, he's been fabulous, eating, growing like a great baby.
So that concludes our case of Melissa. And I think that the 2 cases we discussed, both of her kids, are an excellent representation of how ultrasound can save lives in very different ways. In the first case, we have a diagnosis of congenital heart disease. And in the second case, we used ultrasound to diagnose the fetal arrhythmia, and we're able to medically convert that by treating Melissa. And we thank you for listening to our presentation today.
Thank you, Melissa and team. Next, we will hear from Emma and her doctors.
Hi, I'm Emma Carney. I was a triathlete. I was the world's best. I was world champion a couple of times, world number one over a period, I think it's the longest reign in the history of the sport, over 3 years. I won more races than anyone in the history of the sport. I think that record still stands. It was a period where I was very, very dominant in the sport. It was a period where, well, my career started, the first race that I ever did in triathlon internationally was a world championship that I won, and I won it by the largest margin in the history of the sport. So it was a very devastating, very sort of dominant career that I had in triathlon. I been inducted into all the halls of fame, Sport Australia, World Triathlon, Triathlon Australia. So it was a career that really left a mark. And when my heart condition was diagnosed and my career was abruptly ended, it was quite a significant sort of wake-up call to triathlon. So as a young kid, I was just doing athletics. So I was a distance runner, and I was very fortunate. I had a father who was very aware of burnout. So I was very much held back. So it wasn't so much initially an overtraining sort of, from a young age problem that developed my heart, or that wasn't really considered to be that sort of problem. So my heart condition developed about 3 years into my triathlon career. So I was probably about 26. I still won another world title, but what I noticed personally is that I had a lack of energy, and it sort of hit me in waves. So if I had my racing was very much about sudden attacks and devastating moves and things that broke up the races. So with my heart condition, I had these weakness sort of feelings, and I would just back off and get through. So they started to affect my racing outcomes. I was back in the field. I started to finish top 3, and gradually as things got worse, I was sort of slipping out of the top 10, and eventually got to the stage where I was struggling to finish races with a real lack of energy. I didn't really tell anyone because, as an endurance athlete, high performance athlete, that's soft. So I didn't tell anyone. I just thought it was me, and I carried on training, and I probably did a little bit more damage because I actually trained a little bit harder, more intensely, looked for answers just through training. I thought perhaps I had some sort of, I'd become weak. And it wasn't until about 6 years later from the first signs of these problems that I actually was in a swimming pool in Canada, and I pushed off the wall, felt weak, and suddenly my heart started racing in my chest, and I thought it was a panic attack. Forced myself to finish my racing, my training, and got out of the pool really struggling to breathe, and I thought maybe I'm just having a panic attack. I got myself outside, and the team management was out there, and no one really showed much interest, so I didn't make a thing of it because we had a race in a couple of days' time. And cut a long story short, I ended up on the side of the road. The team bus had driven off on me, and I had got out because I couldn't breathe. The tightness of the arrhythmia was sort of pulling my chest closed. So I ended up on the side of the road. Someone called an ambulance, and I ended up in hospital. Much to Professor Harper's amazement, I was externally defibrillated while I was still conscious, and I really don't recommend that one at home. But yeah, I was in hospital for 10 days, sent home to Australia, no real diagnosis, and the Australian Institute of Sport put me in contact with Professor Harper. And I spent a couple of months doing a number of tests, and me being an athlete, I thought I'd be returning to racing soon. So I was always hurrying up Professor Harper and saying, why do we have to wait a couple of days for tests? And so the diagnosis and the treatment, very, very hard to take as an athlete, because you go from being the fittest athlete in the world, or one of the fittest athletes in the world, to suddenly needing a device inside your chest that's going to monitor you and look after you. And it's a very sort of frightening time as well, because you've got something that you really didn't think that you'd ever need. the diagnosis wasn't done well with the sporting industry. So when you retire, it doesn't matter how great you are as an athlete. My national federation didn't even announce my retirement. The Australian Institute of Sport sent me a letter to thank me for my contribution to Australian sport. And the only people that really, really were there 100% behind me outside of my family were my cardiologists. And even today, I can, because you have a condition like this, your cardiologists are kind of stuck with you for life. So my cardiologists have been extremely important in my recovery. And, I think it's really, really good that this sort of awareness is made. So I'd like to thank you all for bringing this to everyone's attention.
Hi, my name is Richard Harper. I'm Emma's cardiologist and physician. So between 1995 and 1998, Emma was the #1 world-ranked triathlete. But after 1998, her performances started to fall away, despite the fact that she was training harder than ever. So why was this the case? And what happened in Canada, where she collapsed on the roadside after a swimming session and was found to be in VT by the ambulance and cardioverted on the spot, admitted to hospital with no cause found. She returned to Australia, and shortly after returning to Australia, Emma had a further episode of VT whilst running, requiring similar treatment. So here's a 12-lead ECG of her in VT. The QRS morphology suggests the right ventricular origin. Here's her baseline ECG showing a sinus bradycardia with T-wave inversion in leads V1 to V3, which is commonly seen in endurance athletes. So Emma had a series of questions, the most pressing of which is, when can I get back to training? So to try and sort this out, we did a series of investigations as listed on this slide. Here's a 4-chamber view of the echocardiogram showing dilatation of all 4 chambers, which is not uncommon in endurance athletes. But the right ventricle did appear to be disproportionately dilated and with reduced function. And here's an MRI, and you can quite clearly see that the right ventricle is markedly enlarged, particularly compared to the left ventricle. And most importantly, a lot of the right ventricular wall is replaced by fibrous scar tissue. A coronary angiogram, as expected, was normal. At EP study, we could easily induce the VT and it could easily be terminated. It was localised to the posterolateral aspect of the right ventricle. Unfortunately, an ablation attempt was unsuccessful, but we did perform a right ventricular biopsy. And here's the right ventricular biopsy showing hypertrophied muscle interposed with quite significant amounts of fibrous tissue. So at the end of these investigations, we had evidence that the right ventricle was enlarged and damaged, and that the VT was arising from the right ventricle. Our differential diagnosis was arrhythmogenic right ventricular dysplasia cardiomyopathy, ARVD, or something else. Now, as you know, ARVD is a hereditary condition in which the muscle of the right ventricle is gradually replaced by fatty tissue. This leads to episodes of VT, often precipitated by exercise, but exercise is not the fundamental cause of the problem. So we didn't think Emma had ARVD because there was no family history. We thought it unlikely that she would have reached world championship status with this condition. And there was no evidence of fatty infiltration of the RV on the cardiac biopsy or MRI scan. And although not available at the time, subsequent gene testing for ARVD has been negative in Emma. So just comparing the biopsy of Emma versus typical ARVD, you can see fatty tissue versus fibrous tissue. So what does Emma have? Well, the clue came from this paper published in 2003 in the European Heart Journal by Hein Heidbuchel and Associates on high prevalence of right ventricular involvement in endurance athletes with ventricular arrhythmias. They had 46 high-level endurance athletes who presented with ventricular arrhythmias. In 89%, the arrhythmia arose from the right ventricle. Now, 9 of these 46 athletes died suddenly, none having received an AICD. So it clearly was not a benign condition, and it isn't a benign condition. None had features of familial ARVD, and subsequent genetic testing has confirmed that. They then further looked at right ventricular function in these athletes, and it was reduced. And they came up with a new diagnosis or new term, exercise-induced ARVD. The name has changed slightly. There's been slight variations of the name. They believe this is a condition distinct from familial ARVD, and this is the condition that we think Emma has. It's basically only seen in high-level endurance athletes, particularly cyclists. The presentation is ventricular arrhythmias, and the characteristic feature is right ventricular enlargement with evidence of fibrosis rather than fatty infiltration. The postulate is that episodes of extremely intense endurance exercise leads to small amounts of damage and fibrosis of right ventricular muscle. Eventually, the cumulative effect may be severe enough to cause ventricular arrhythmias. That is, this condition is an acquired condition, the causative factor being extreme exercise. And the implication being that it is possible, at least in certain individuals, perhaps with a genetic predisposition, to damage a normal heart by extreme endurance exercise if performed often enough. It's an important implication. So how did we manage Emma's condition? Well, the obvious thing was to avoid high-level exercise, but that's not an easy thing in a champion athlete almost addicted to exercise every day. So we had to find some method where Emma could still exercise, but not to extremely high levels. And insertion of an AICD has saved the day. So what we found when we exercised Emma on the treadmill, whenever her heart rate got to 150, she went into VT. But the device terminates it by burst pacing. And of course, there is the backup if she goes into VF of a shock. And over the 15 years that Emma's had this device, she's had about 7 episodes of VF, mainly occurring when she's exercised higher than she really should. But over the last few years, she's had no shocks. She's learned to exercise to a level just below 150 beats per minute. So to summarise, we believe Emma's heart condition is a result of an extraordinary amount of very intense exercise over a long period of time. And fortunately, the condition can be managed thanks to the AICD, still allowing a reasonable quality of life. We did write up her case, and I'll finish by just showing her current echocardiogram or some video clips. This is a 4-chamber view. You can see the defibrillator lead. The long axis function of the right ventricle seems pretty reasonable, but and this is the parasternal long axis view, and you can see at the right ventricular outflow tract that the contraction is very poor. And finally, the subcostal view. But perhaps Dr. Field could comment on this. So I'll end there.
Hello, my name is Dr. Dermot Phelan. I'm Director of Sports Cardiology at Atrium Health and Sanger Heart and Vascular Institute. And I'm absolutely delighted to be here today with Emma and Emma Carney and Dr. Harper. Want to thank you, Dr. Harper, for a very elegant presentation and succinct presentation of Emma's case. And I particularly want to thank you, Emma, for sharing your story today with us, because this is not a common entity and something that people probably misdiagnose quite a bit. And so I think it's important that we get this information out there. I think it's important for us to start by discussing a little bit the actual physiology of exercise and recognizing, that athletes like Emma, endurance athletes, will, increase their cardiac output 5 to 6-fold and maintain that for hours on end. And the heart adapts to that by changing from an electrical perspective, and Dr. Harper pointed out some of the changes on the ECG that Emma has, and from a functional and morphologic perspective. There's a term for that called the athlete's heart. And so most of the time, an athlete's heart, we consider that a completely benign physiologic adaptation of the heart for the heart to be more efficient to be able to exercise at high levels. But it does sometimes cross over with pathology, and we saw the echo images at the end of that study. We saw Emma's right ventricle was dilated, the function was reduced. And the question, I guess, to begin with you, Dr. Harper, is how do you go about trying to differentiate for an athlete who comes into you with perhaps non-specific symptoms, maybe not as dramatic as Emma has, but who has a dilated right ventricle, who has maybe some reduction in function? How do you differentiate that from pathology? Good question, a difficult question. I think perhaps the MRI is the most useful, because if there's evidence of fibrosis on the MRI, I think that's a sign that this might be an early stage of this condition.
I think you need a certain amount of fibrosis before you start getting ventricular arrhythmias. So I think the MRI, once you've got the echo signs of perhaps a disproportionately enlarged RV, I think the MRI is probably the best next test.
Yeah, I think that's right. And the key there is the disproportionate RV enlargement, isn't it? So I mean, you know, the both right and left side of the heart should be exposed to the same hemodynamic stress. So you'd expect 4-chamber dilation there, and when the RV is significantly bigger than the LV, then that kind of raises some red flags. You know, we use a ratio of RV to LV of greater than 1 as a sign that perhaps there's a problem. But we certainly do see athletes of Emma's caliber that will have some mild reduction in RV function. But I think a key here is when they exercise, that function improves dramatically. And I think one of the big features that sometimes trip people up is when we think of the task force criteria for ARVC, it's not just about RV size, it's also about showing areas of akinesia, dyskinesia, or aneurysms, abnormal contraction areas related to that fibrofatty replacement. So it's not just about size. I see sometimes these MRI reports going out saying this is a very enlarged RV consistent with ARVC, but that's not accurate if they don't have some of those other features there. And so, you know, I think the entity that we're describing here with Emma, though, is a little bit different than ARVC. This is a kind of new concept of exercise-induced arrhythmic cardiomyopathy. And so I think, you know, would you mind, Dr. Harper, maybe discussing how you discuss exercise with athletes who, one, have ARVC, because I think that's one conversation, versus an athlete like Emma, who we feel this is more exercise-induced cardiomyopathy.
Yes, well, I think the familial ARVC is basically a genetically distinct condition from Emma's condition. And those patients with that condition, it's a progressive condition where the fatty infiltration of the right ventricle progresses over time. So, and those people are subject to ventricular arrhythmias, particularly during exercise. They cannot exercise, and they usually need a defibrillator. But it is a progressive condition, whereas exercise-induced RV dysplasia, presumably if you stop extreme exercise, you will stop adding to the fibrosis of the right ventricle. So I think it's important to distinguish between, first of all, does this patient have familial ARVC, or is this a form of exercise-induced ARVC? And they are genetically distinct conditions.
Yeah, I completely agree. And obviously, for the genetic ARVC, that's an even tougher conversation, I think, because you know, even people who have a structurally normal heart that have the gene mutation, we're concerned that intense exercise may actually shorten the period to the point where they start to manifest the disease. Yeah, and so I think that's sometimes an even more difficult conversation with that particular problem. Emma, I just wanted to turn over to you for a second, and before I was going to one of the questions I was going to pose to you was, what could the medical profession have done better? Because when I see athletes like yourself, it's often that they're coming to me on the third and fourth referral, and they really are frustrated that they've not been able to get a diagnosis or an answer. But yours is a little bit different. You said in your discussion there that really you were lucky enough to meet Dr. Harper early, and Dr. Harper was really the one who helped you through. But I think the question for you is, how do you feel the medical profession can highlight this particular issue, or what do you feel that we need to do to help athletes who have been in your position?
Well, I was very fortunate to be referred to Professor Harper. And I do think it's quite difficult for the Medical Federation because my case is quite high profile. So there's a lot of triathletes and a lot of athletes, distance runners, cyclists that contact me and say to me, you know, how do you continue to exercise? And because everything always looks good from the outside, no one's actually seen the struggle and the fact that my life is completely different to what it used to be like. They might see me out running, but I'm not running like I used to. So I think it's very difficult because, you know, physicians have to save people from themselves in a way. And I think that would be a struggle to do because some people wouldn't accept the fact that they can't exercise because I saw Emma Carney running the other day. So I think the care that I received, you know, initially there was discussion that I'd never exercise again. And Professor Harper could obviously see that that was probably going to kill me quicker than the VT. So we've sort of got to a stage and, you know, my first defibrillator only lasted 5 years. I set it off that many times. And while I've been externally defibrillated and the little shock that you get from the internal defibrillator is quite so much better to receive, it's still not nice. So, you know, maybe I'm one of those people as well that is a little bit needs saving from themselves.
You know, I think that that's a profound statement that lack of exercise would have killed me quicker than the VT. And, you know, I think that that's something that as cardiologists, we really need to recognize more. And I think that that's where, I guess, the field of sports cardiology has been born from, where, you know, to have people who deal specifically with athletes that recognize the difficulty athletes face.
Well, I think the problem is with athletes is that we're used to doing things that are seen to be impossible. So if someone says, oh, well, that's never been done before, to me, that's not an issue. Okay, let's try. So that's, you know, that's the problem that Professor Harper had with me, because the fact that it had never been done before or we don't know, that isn't really, I've never really found that as a concern. I've actually liked doing things that haven't been done before.
Well, look, Emma, thank you so much. And Professor Harper, thank you so much. I think we'll wrap it up here and look forward to some questions from the audience.
Hello, my name is Judy Hung, Boston, Massachusetts, and I am co-moderating the Q&A for this session with Dermot Phelan from the Sanger Heart Institute in North Carolina. I want to thank Melissa and Emma for sharing your stories with us. And I'd like to start with some questions I'll also introduce the rest of the panel. Dr. Joanne Chu, who was a pediatric cardiologist for Melissa, and Dr. Richard Harper, who is Emma Carney's cardiologist. First, some questions for Joanne. One of the questions was, with congenital heart disease, with what would be the incidence or risk of a second child also having congenital heart disease, having one child already being diagnosed?
Yeah, that's a great question. For a sibling with congenital heart disease, it's about 3%. So alone, without any arrhythmia issues, that second fetus would have been an indication for a fetal echo referral. But it turned out that Madison, her first child, had a small microdeletion in 8p23 with a GATA4 deletion. So they felt that that was the etiology, the genetic basis for her congenital heart disease. Both parents were negative by PCR. So there was some reassurance for future pregnancies from that respect. But regardless, all future pregnancies would have been screened by us by virtue of the first sibling having congenital heart disease.
And then I wonder, in terms of what kind of genetic counseling you recommend for both the child with congenital heart disease and for the parents?
Yeah, so for the first pregnancy, because there was an increased nucleotranslucency, that automatically funnels into the genetic counseling area in your OB care. So they elected to go for chorionic villus sampling, which can be done early on and have that genetic information done. But for the second pregnancy, I think given what they knew had happened with the first pregnancy, the parents elected to not do a more invasive genetic procedure like CBS or amniocentesis, and instead opted for cell-free DNA, which is blood sampling. And with that being reassuring and having the heart structurally normal on the echoes, aside from the arrhythmia findings, they elected not to do CBS or amnio. Automatically, they would have gotten the genetic counseling by the family history.
Yeah, and as a follow-up to that, I mean, this obviously is a very emotional time for the families and the team members as well. And as part of your team, do you offer counseling for support, or what kind of resources do you have for that?
Yeah, so we work very closely with the maternal fetal medicine group at MGH. We kind of go hand in hand. So the social work support comes from both groups, as well as a new creation of a family support group. So families who have been through similar fetal diagnoses and postnatal courses are able to discuss with each other. And it is a very sensitive time. Not all parents choose to continue pregnancies. And it is helpful to talk to families who have made different choices and different decisions with their diagnoses.
Mm-hmm. And in general, with when you first diagnose patients with serious congenital heart disease in the fetus, what is in general the follow-up like? Is it a sort of repeat scan every, or depends on obviously the lesion? But what was it like for Melissa?
Yeah, it depends on the lesion. So typically our referrals happen between that 18 to 22 weeks because their level 2 ultrasound or the anatomy scan happens at that time. If there is a known history, for example, if there is a prior child with hypoplastic left heart syndrome, it's obviously more beneficial for the family to get as early a scan as possible. So my colleagues around the country and the world can scan up to 12 weeks, and we would offer as early as possible, knowing that we may not get all the anatomic structures, but potentially we could diagnose a second hypoplast, and the families can again make decisions earlier on than later on in pregnancy, being sensitive of every gestational age mattering. And then in terms of the follow-up, you're absolutely right. Different lesions have different prognoses and physiologic changes during gestation. In particular, the atrioventricular canal defects, we would monitor regularly for increasing degrees of either left or right-sided AV valve regurgitation, and for function and rhythm if there was a heterotaxy concern, for which there was none.
We have one question regarding the second case with the fetal arrhythmias. And that is in regard to the dosing of the digoxin. Obviously, you're treating the fetus in this case, and how would the dosing go in that case? Is it just sort of a regular therapeutic dose, and then you follow with the Doppler, or do you sort of aim high?
Yeah, that's a great question, because absolutely right. We're treating the mom, and that goes hand in hand with every maternal side effect you can imagine or would look for too, in the hopes of it reaching the placenta and treating the fetus. So we do target digoxin levels between 0.7 to 2 nanograms per milliliters, and we check this after the loading dose is complete. If it is low, then we adjust the dose. If it's high, we adjust the dose, and we check a few more times after. And in her situation, after the IV, and in some cases, you could do a PO loading dose. It was stable and within normal range, and she herself was asymptomatic. We continued with the BID PO dosing for the rest of her pregnancy and had no complications and no recurrence. It was a successful medical conversion of the tachycardia.
So basically, it's just sort of standard therapeutic dose range, perhaps aiming high, but the end result is making sure the arrhythmias are controlled.
Yes. Yeah, we're not eliminating the arrhythmia completely. We're just getting it to a controlled state so that there's no impact on function, certainly no high drops. And at MGH, again, we have an excellent adult cardiology team that follows the mom specifically in terms of monitoring on telemetry, having daily EKGs, and making sure that she's not having worsening symptoms from the maternal dig loading and/or maintenance dosing.
And one last question regarding the arrhythmia. What is the sort of expected course for the baby? Are they more at risk for arrhythmias, once they're born, or if this is just something that happened in utero and hopefully won't happen again?
That's the reassuring thing for fetal arrhythmias, is most of the time it resolves upon birth. And if not, then definitely by 6 months to a year, it would be surprising for this to extend past that date. So although it is a pretty scary diagnosis to get during pregnancy, especially for a mom like Melissa, who had been through so much before, there is that other side of, this is probably going to be fine, which ended up being exactly the case for Logan.
Well, thanks very much. That's very reassuring. So it tends to go away. So
Yes.
I'd like to thank you, Joanne, for setting this up and organizing this wonderful story. And I want to thank you and your team and Melissa.
It's our pleasure. Thanks for having us.
Okay, Dermot, please go ahead and there are a number of questions for Emma, I see.
Yeah, thank you so much, Judy and Joanne. That was a really phenomenal discussion. And now we're going to shift gears a little bit and talk about a different presentation here. And it's a real pleasure to have Emma Carney actually here with us. Obviously, Emma is one of the greatest triathletes of all time, and really want to thank her for sharing her story. And Emma, I'd like to begin with you, if that's okay, and then we'll move to Professor Harper and ask some questions for him. But Emma, could you tell us a little bit about how you would advise other athletes that have heart disease? How do they integrate their athletic lifestyle with their diagnosis of heart disease?
Well, that's a hard one. Whenever anyone asks me that, I always say, ask your cardiologist, so I can refer that back to you. Really, really, really hard to answer that one. No one really knows, I don't think. And I'm very, very fortunate that my heart condition didn't kill me, and I was diagnosed as I have been. And while it did end my career and, ended up ruining my career to an extent, the fact that I'm able to keep myself fit and still have exercise in my life, I think is a credit to my cardiologists, because they allowed me to, the diagnosis wasn't just, okay, you need to stop now because this is killing you. And we sort of sat down and worked out, well, how about we see what I can do and work within the boundaries that my condition gives me. So I think it's all about, I think both sides have to have an open mind and think about the diagnosis. And, I did lose the ability to race, and I have actually done a couple of races since my diagnosis, and I have white line fever, and if I pin a number to myself, I forget I have a heart condition and I set my defibrillator off. So racing is completely off the charts. We worked that one out early, and they were even fun races. So work out your limits and work through, keep yourself, I have to see my cardiologist regularly for checkups, and just manage your condition.
Yeah, I think that's exactly right. And, unlike a lot of areas of cardiology where we've got databases of tens of thousands of people, there's not too many Emma Carneys out there. And so, we don't have that database to go back to. And a lot of this is down to shared decision making and figuring some of this out with the patient. And you mentioned during your talk that your ICD went off so many times that it had to be replaced early. Can you talk a little bit about how the effect the ICD has had on you has it been a reassurance for you? Has it been something that worries you? Tell us a little bit about the psychological aspect of that.
Well, initially, so when I was diagnosed and I was told that I needed to have an ICD implant, I was sent home for a couple of weeks, because the appointment was coming up. And that was actually quite a scary time, because I sort of felt a little bit free range. Anything could happen and I didn't have any backup. So the ICD does give you that backup and gives you a little bit more confidence in your ability to stay alive. But it's also, I found it a little bit insulting because I'd, never smoked, never done drugs, never done anything bad for my health. And here I was at the age of 34 and I had a chunk of metal in my chest looking after my heart. So that sort of wasn't in the whole brochure of my life. But you adapt as humans do, and you learn to accept things, and time heals a lot of problems in your life. And the support that I received, well, I didn't receive any support from Australian sport, so that was that does need to change, and the understanding and the care of athletes in that side of things. But the support I received from my cardiologists, very, very patient with me. They were, I have Prof's mobile number, and I ring him every time I set it off, and he always asks me what I was doing. And I'm always doing something stupid. So I call it a competitive situation, and he knows what I've been doing. And I think I've ruined a number of his weekends on the golf course. But yeah, we've worked our way through, and while it's not ideal, I'm still here, and I'm able to coach, I'm able to exercise, and I train with my athletes that I coach. So it's still swim, bike and run in my life.
Okay, great. I'd like to bring Professor in here. There's one question that's come in through the chat, and it refers to screening. So obviously there's lots of variations on how screening is done in various parts of the world. And the question is there any talk of a national or international athletic heart screening program? And I guess what your thoughts would be on what such a program might look like, and do you think that that's a good idea, Professor?
Yes, I think it would be a good idea. I think it's going to be hard to identify endurance athletes that will run into the sort of problems that Emma has just from baseline screening with an echo or an ECG. It would need to be genetic screening, but we need to understand what genes are involved. Now, we know that there's quite a few genetic abnormalities affecting the desmosomes related to ARVC, but that's the extreme end, more the extreme end of ARCV, where people have a familial problem. They manifest arrhythmias early in life. They're not not necessarily having done a lot of exercise. We know that exercise in those people bring on the arrhythmia and probably worsen the condition. But we don't know, are there people with completely normal baseline echo function who want to do endurance athletic activity? Can we identify a group where continued endurance activity may result in significant right ventricular damage? And I don't think we're there yet, but an international registry looking at the gene profiles of people like Emma would be very useful.
Yeah, I think it's
one thing to say.
Sure,
I was going to
please.
say, just with regard to Emma's previous comment, what we've learned with Emma is that if we exercise her and she gets a heart rate of 150, she gets VT. The device will then override the VT, but occasionally VF. So we have tried to train her to exercise to below a heart rate of 150 and everything's fine. So I think you can work out a graduated exercise program for people in Emma's situation. Whether they necessarily strictly comply to it or not is a different matter.
So on that question, how do you treat medically Emma's condition or similar conditions? And do you treat athletes differently than you treat other patients that may have ARVC?
I think people who have ARVC and are not particularly interested in exercise, we generally when by the time of presentation, they're going to need a defibrillator, a prophylactic defibrillator, and we generally advise them not to exercise to any major extent, because in that condition, exercise, there is now evidence that exercise hastens the progress, hastens the degree of fatty fibrosis. With Emma's condition, which we think that every time she did an extreme endurance activity, she had a little bit of myocardial damage. The right ventricle hasn't progressed. The right ventricular damage hasn't progressed over about 10 or 15 years. So I think that's encouraging, even though Emma's doing what many would regard as a fairly high level of exercise.
So do you
And
think,
one other thing,
sorry, go ahead.
I was going to say, we don't, in Emma, we tried beta blockers to see if we could stop her getting to a heart rate 150 more easily, but she didn't tolerate beta blockers. And my experience with athletes is they hate being on a beta blocker. So she's on no medication.
Okay. Yeah, I think that's right. I think it's more challenging with athletes. They tend not to like that reduction in their heart rate, that reduction in functional capacity. It tends to make them, they tend to have a lot of difficulties with beta blockers, although it doesn't have the effect on heart rate in athletes that it does tend to in other populations. So Emma, could you want to make a comment on the medical therapy and how you felt with that?
Yeah, just the comment on beta blockers. I found them, they slow you down so much that you not only can't train properly or exercise properly, but you also feel awful doing it. And I just hated that feeling. So I just said, oh, look, let's just see if I can be sensible rather than having to take them.
And I do think that there's no doubt that happens in many athletes, but certainly it's not uniform. And I've got a lot of athletes that do tolerate them and do very well with them, but no doubt that unfortunately that wasn't the case with you. Well, look, I think that we've run over time a little bit here, but it was worth doing so. Emma, once again, thank you so much for joining us. Professor Harper, thank you also. Dr. Hong and Joanne, thank you also. Dr. Hong, have you any final words?
No, just it was a great session, getting a lot of Twitter discussion already on this, and thank you all for putting in the time to be here with us.
Thanks for having me.
Thanks for having me.
Thank you.